tonight. I know just from the practice, get to know you session we did the other day that we can easily fill an hour with this topic. So I want to just dive right in and get started because I'm sure we're going to need every minute. And I have, of course, am Manu Koenig, running for supervisor here in the county. I will do. There's plenty of time that you can get to know me better. I do a regular weekly town hall meeting. We did one just last night. You can learn more about me and my platform and background. But tonight is really about the panelists that we have here who know homelessness as well as just about anyone in the state. And so I really want to make sure they have plenty of time to talk. So I'm going to start by just giving a little bit of background about homelessness and mental health in our county, just to kind of ground us in a few facts. And then we'll turn it right over to introductions of you three. And then we'll save some time for audience questions at the end. So I'm going to go ahead and let's see here one moment. I will share my screen and just show, let's see. Okay, great, there you go. You guys all see this little graphic here of our event tonight? Panelists, can you see that?
Yes.
All right, awesome. I think the first thing I want to point out is that this is a picture of the San Lorenzo River Camp, and it's right by the county building here in Santa Cruz. And there's actually a reason for that, and that is that the county is chiefly responsible for homelessness and mental health in our community. Many people don't realize that because here in Santa Cruz County, many of the folks struggling with homelessness and mental health are in the downtown city area. And so people think that it's the city's job to deal with it. But the reality is that much of the state money, federal money that comes into our community to try and improve this situation really flows through the county. And when the chief of police for the city of Santa Cruz, Andy Mills, first came on, he actually organized this camp or helped to organize it in front of the county building, partially so that county leaders every day would realize that here is the issue that they needed to address and to work on it. This camp has been on and off in the same spot for the past 4 years now, and of course it's there today. But I think it is important to remind everyone this is a county issue. This is some of the numbers around homelessness in our community. So as you can see, this is from a point in time count that happens every year. And basically people get up at 4 in the morning and go and try and count as many people in every part of the county as fast as possible. And so it's not completely accurate, but it is some of the best information we have. You can see that other than, kind of ameliorating this spike we saw in 2007 and 2013, from 2009 to 2019, in the last 10 years, we haven't made a whole lot of progress on this issue. So there's a little more than 2,000 people suffering from homelessness in Santa Cruz County. And that number has not changed greatly in the last 10 years. And then you also point out that many of those people are unsheltered. So as you can see on the right here, 22% of people are sheltered and 78%, the vast majority, are unsheltered. And of course, there are many subpopulations within this group. It's not a homogeneous group. So you have chronically homeless individuals, veterans, families, unaccompanied children, and transition age youth who have aged out of the foster care system. And then, of course, as we'll discuss a little more tonight, many of the folks dealing with homelessness are suffering from some kind of health issue. So these are self-reported issues reported during the homeless census. You can see 32% psychiatric or emotional conditions, 30% alcohol and drug use, 30% post-traumatic stress disorder, 26% physical disability, 21% chronic health problems, 12% traumatic brain injury, and 3% HIV or AIDS. So yeah, and in total, 39% had some kind of disabling condition. So in fact, a lot of the time it's these disabling conditions that lead someone to fall into homelessness. And just one more point here. The grand jury, the citizen grand jury here in Santa Cruz County issued a report in June of this year called Homelessness, Big Problem, Little Progress. It's time to think outside the box. And it really just delved into the fact that we haven't made a whole lot of progress with this issue over the last 10 years. And it suggested some solutions. And that's really why we're here tonight, is to explore what those solutions look like and begin to put together a roadmap for our community. And that's why I've invited these three very intelligent panelists here tonight who are all doing this work in other communities as well and having great success. So now I will turn it, I will go ahead and introduce them. So I have with me here tonight, Mark Burns. Mark, thank you for waving your hand. Mark is the Executive Director at Homebridge since 2015. And a Homebridge is a assisted living program that helps people in long-term care situations. Mark is based in San Francisco. And welcome, Mark. I'll give you a chance to talk a lot more about your program here in a moment.
Great.
But yeah, thanks for joining us.
Lovely to be here. Thank you.
Keith, Keith is welcome to be here. Keith, thank you, Keith. Keith is currently the Veterans Program Manager at Home First in San Jose, where he oversees all housing and homeless shelter programs for veterans and their families. And he's worked in the affordable housing field for over 15 years. Keith is a resident of Capitola, even though he does most of his work over the hill. So also, of course, deeply invested in seeing solutions for our community. So thank you for being here, Keith.
Thank you for having me.
And Jill, welcome, Jill. Jill has over 30 years of experience in nonprofit operations, and she's currently the Executive Director of Transitions Mental Health Association based in San Luis Obispo. And Transitions Mental Health Association is a community-based agency, and Jill is responsible for budget development, supervision of staff, administration of business and contracts, all kinds of important things. So thank you for being here, Jill.
Thanks for inviting me.
So I want to let you guys, talk about your programs in more detail. And so why don't we just go in the same order that I introduced all of you. And let's start with you, Mark. Yeah, please tell us more about Homebridge and your program.
Sure, thank you very much. And I really appreciate your having us over today, and Nancy Ellen for inviting us to be part of the panel. So Homebridge is a community-based nonprofit organization in San Francisco. We're basically a home care agency, but we are part of the county's in-home supportive services program. IHSS, for those of you who are familiar with it, is a Medi-Cal beneficiary program that provides in-home care for people who are assessed as having disabilities that require anything from domestic support with cleaning and food to personal care or paramedical services. It's predominantly a family caregiver program, support program, but we serve about 3 to 5% of the population that has no other family connection, folks who live in SROs. About 2/3 of our population has previously been homeless, and we help them with maintaining stability in housing. Our folks all have some sort of behavioral health condition which complicates their ability to receive care and therefore makes it difficult for them to remain stable in their housing. Anything from medication management and helping them with visits to doctor's appointments to doing hoarding and cluttering abatement. So we help with lease violations by removing conditions which would make them lose their housing. In the recent months, we have been also caring for folks in Project Roomkey hotels who are all obviously being distributed to lighten the burden of COVID in shelters. So we're caring for a couple hundred folks right now in 18 different sites in San Francisco, all of whom also again have behavioral health conditions. So about a third of our population has a substance use diagnosis. More than a third has another mental health diagnosis, and about a third of our population has some form of dementia as well, or other cognitive impairment. That's what we have. We're a large organization. We have a full-time staff of 300 plus caregivers. And then we do a lot of heavy case management services on top of that with another 85 full-time case management and administrative staff.
That's
awesome.
awesome.
Who we are. Yeah.
Yeah. Hey, and you shared this slide with me, which I'll share with the audience now, which shows some of the impacts of your program. Maybe you want to talk about this briefly?
Sure. I think, folks come to us only by referral, and it's a program of choice in San Francisco. So folks who come to us typically are in crisis, often coming out of transitionary shelters or into housing for the first time since they've been homeless, or who have been in the independent side of the program and are failing out of it because they're ending up in institutional care systems frequently. So, our goal is to stabilize people in housing. And so what you see here are some statistics on how our service helps folks reduce the number of hospitalizations, trips to the emergency room, 911 calls, a significant impact on lease violations, missing medication doses. And as those of us who work in mental health all know, missed medication often leads to psychiatric episodes, which often leads to 5150 calls, which often leads to hospitalizations and sometimes longer term institutionalization. So all of these impacts are really designed, our program is really intended to sort of cut down on the ability for folks to be sort of unmonitored and to have negative impacts on their life. So thanks for showing that slide.
Definitely. Yeah, you're clearly succeeding. Great. Keith, why don't you tell us a little bit about your work?
Okay. Well, as you said, I've been in this business probably a little bit over the 15 years. I was just probably trying to hide my age. But I've been working in affordable housing for probably over 20 years. I've worked with HUD in different cities from Indianapolis, Kansas City, Las Vegas, Atlanta, Georgia, all trying to, deal with the affordable housing problem. Here in California, I've worked for Santa Clara County Housing Authority as a senior policy analyst, and currently, like you said, at Home First as a veterans program manager. We serve about 250, I'd say, veterans here, many for supportive services. For housing in particular, we serve about 100 altogether. We have sites in Willow, which is in Menlo Park, which is a project-based HUD-VASH property. Here on site where I'm at in San Jose, we have emergency housing for veterans. And we also have emergency housing for veterans, special circumstances, which are criminal convictions of some sort. And then we have interim housing, which is a bridge housing almost, to help them get from shelter, get the interim housing piece, to try to get the permanent housing piece. As you said, with some of the statistics here in Santa Clara County, we've had explosion here the last couple of years. COVID is going to make that worse. We're probably anticipating our numbers to jump another 30% of what you're seeing for the new PIC count. I think that'll be coming up at the end of January, I believe, in 2021. So we'll get the updated numbers. With that, with the eviction, referendum that we're having right now, who knows what those numbers will look like. One of the big things that we're looking at, I know people probably heard of the tiny home situation. So we have the shelters done. We built a lot of more of the interim housing or bridge housing, as we call it, which are the tiny homes. Another big, huge problem, though, is the permanent housing piece. I know me and you, Mano, have talked about that, of trying to build enough affordable housing for homeless, but even just low-income people or middle-income people. That's a big issue. Part of that problem in the policy issue or issue side of it is the policies, land use, looking at land that is underutilized, but also making it where the people do not feel isolated, where they won't get services. So we're trying to look at all of that. I know Santa Clara County just came together with all the providers to get a strategic plan for the next 5 years, which we came up with some general goals, in general, try to develop a plan to help But it starts, with people like us, people like you, community getting ideas, us all being on the same page, coordinating our services together so we're not duplicating services, finding out what gaps are needed, what and what we can do to fill in those gaps if they aren't. Just, I know you had the slide before that showed all the reasons for it. Some things that jumped out at me from looking at that. Um, the numbers are disparaging between race. We find a lot more females and children now that are finding themselves homeless, and people that never did before, first time people find themselves homeless. So there's a lot of issues there to tackle. And I think panels like this will help us all get together and come up with ideas, people from different areas, find out what works, what doesn't, putting our minds together and coming up with a solution, because it's a moral issue as well as financial and everything else.
That's awesome. Yeah, thank you, Keith. And I think it's really fantastic that I've done so much work with veteran services. As we saw on some of that information I shared, 85% of veterans here in Santa Cruz County are unhoused, and so it would be really great to bring some solutions like that to Santa Cruz County.
Yeah, and even with our outreach, we're probably finding about 10 to 12 new homeless vets a month. So the problem's still there.
Mm-hmm. Yeah, a lot of work to do.
Mm-hmm.
Jill, you are working on this problem, I think, from all kinds of angles down in San Luis Obispo. And tell us a little bit about the different ways you guys are having an impact on homelessness and mental health in SLO.
Sure. So San Luis Obispo is similar in size to Santa Cruz, has some similar elements in terms of some agricultural parts of the community, tourism, and coast. So I think there are a lot of parallels. My organization, Transitions Mental Health Association, is actually, the mission is primarily about mental health and behavioral health. So that was actually how it was founded many, many years ago. But I think, as both Mark and Keith talked about, there is a lot of intersection with mental health, substance use, and homelessness. And in fact, your slide that talked about some of the data in Santa Cruz County, I think, underscores that. So I would say that my agency's come more recently into looking at the issue at the intersection of mental health and homelessness, but we have found some best practices that we think have been really successful. And I have a couple of slides, so I may actually have you fire up my slides, and I'll talk a little bit about what some of those are. But I appreciated what Keith was also talking about, just in terms of the impact of COVID, and how that's also changing some elements of the game, because it's impacting people, their housing because of employment. And so it's just adding layers of anxiety and stress, and I'm afraid will cause more homelessness. So this slide that you brought up is a program that we started in 2014, and it was very specifically to figure out a way to house the most vulnerable homeless folks. So these are people who were surveyed through that enumeration count that you talked about. Every county in California does one. So in that survey, the question was asked about factors that would cause vulnerability. So a mental health diagnosis, substance use, and other physical health problems. So the Housing Authority put together 70 vouchers for subsidized housing, and we used a Housing First model. And I think Housing First is something that has been found to be a best practice. It basically says, we don't need to wait for somebody to accept mental health treatment or to accept substance use treatment. We don't say you need to be clean for 30 days or 60 days. We say we will take you directly from the street and put you into a housing setting. And in our case, this is permanent housing. And the statistics that are described show what a dramatic impact the Housing First model, with very intensive support with case management, nursing staff. So as you can see, almost all citations and arrests were reduced. So 97%, 98% reduction in jail days, 78% reduction in ER visits, and 89% of a reduction in psychiatric hospital admissions. So those numbers really show that a very intensive focus on housing first and having staff there, while expensive at the front end, and I think both Mark and Keith talked about investment and expense at the front end, and then how much it ends up saving you. If you could go to the next slide.
Okay.
Excuse me.
I've got this one. Do you want or
yeah, no,
or
this is great. This is an example of a housing project we put together, and Keith talked a lot about housing. Obviously, the solution for homelessness is permanent housing. And so this project we were able to put together with the help of the Housing Authority. This was on county property. The brick building was an abandoned orphanage that had been abandoned for 40 years. And we were able to obtain it and build the new housing in front. It has an on-site residential manager. And once again, very intensive case management services. And I know that Mark talked about the success of case management. And one other project that we have that I think is really important, and I don't know if I included that slide, but is the pairing of a social worker or therapist with law enforcement folks. And the city of San Luis Obispo invested in a social worker. So my agency actually hired that person, and that team basically goes out on calls that are including people who are homeless, who appear to be mentally ill. And because the social worker has that training, it completely changes the dynamic with the intervention. And so it has really resulted in some very, very successful connections to our 70 Now program, to Bishop Street Studios housing, and even to reuniting some homeless folks who maybe have gotten away from family because of some of their behaviors that led to homelessness. And so that has proven to be really successful. And we're seeing that as a great gold standard for law enforcement to actually have that pairing of a social worker or therapist alongside them. All right, you can take down the slides. I think that we do have another full service partnership team. It's funded by the Behavioral Health Department, and I don't know if that slide got included, but that's a homeless outreach team that also includes nursing staff. Oh, there they are. So that team includes a whole array of staff. So there's a licensed therapist, there's a nurse, there are case managers, and people who have lived experience with mental illness. And so this team has been, again, tremendously successful in meeting with people who are living on the streets countywide, going to encampments, going to places where maybe there's a reason that law enforcement has to move a group. I know recently there was a group that needed to be moved out of an area that was in fire danger. And so this team gets deployed to talk about some of the options and resources before, somebody comes in and clears out the encampment. And so this homeless outreach team, I think, has been incredibly successful in terms of linking folks directly to getting primary health care, to getting behavioral health care, and making sure that they address all the issues and working to find folks housing. So those are some of the projects that we have found to be really successful in San Luis Obispo. They're extremely replicable anywhere. I think Santa Cruz, has a lot of the same elements. And so I certainly have seen some of that upfront investment really pay off in terms of helping folks get into permanent housing and get the care and treatment that they need to live full and thriving lives.
That's awesome. Thank you. Yeah, thank you, Jill. I'm glad you brought up that pairing of a mental health crisis response, a social worker with law enforcement. That was one of the recommendations in our civil grand jury report, was to implement a program like that. And actually, maybe you could briefly comment on, I think in our grand jury report, we talked about the Cahoots program in Eugene, Oregon. Which is, I believe that's a fully independent, they're their own nonprofit, and they all actually respond just as the sort of health response team. They don't have a law enforcement paired with them. you know, am I getting that right as far as like what's similar and different about your program versus that program?
I'm familiar with the CAHOOTS program. It's a really neat model. It does pair an EMT, so like a paramedic, along with social workers. And from what I understand, they would maybe arrive at the same time or before law enforcement. But you're right, they are independent. And so I think what's great about that, though, is an EMT is in a position to provide some medical care, maybe some administering of medications or first aid, things like that. So I think that the CAHOOTS model is a really wonderful model. And I guess what's different about ours is that our social worker, and he is an LCSW, rides in the police car with the officer, sometimes goes out before the police officer would go, or goes in a pair, depending on the situation, depending on what they think. But he's not in uniform. He usually wears a baseball hat with our logo, and I think it just has a totally different dynamic than having a police officer. So it's been found to be really, really effective in those situations, and even responding to domestic call, like maybe there's a mental health issue within a house. Sometimes there might be an adult, a family member who has mental illness, who's not taking medications, and so the call may be from a neighbor or an elderly parent, and that's another situation that can be really helped by having a social worker as the first person at the door assessing what's happening. So I find it as a best practice. I feel like that's a gold standard that I'd love to see counties like ours, and honestly the state, adopt.
Yeah, absolutely. I mean, I feel the same way. Thank you for that, describing that difference.
If I can add something onto that.
Yeah, please, please.
I know in Santa Clara County, that idea is getting a lot of momentum, and it really, I think it's a really great idea. I had mentioned previously, we have a place, Willow Housing in Menlo Park. And we have a case manager who is a LSW, I believe. And the difference when she's on site and when there's a police call is completely different interaction when just the police arrive themselves. It de-escalates a lot of situations, and it really can solve the problem without any arrest or violence or anything of that nature. So I just really recommend that same approach.
I'm glad.
Fantastic. Yeah. So I mean, I think all of you talked about programs that would be extremely valuable to bring to Santa Cruz County. And so, you know, my question for each of you is, you know, what can best lay the groundwork or enable us to implement these kinds of policies or programs, and what maybe is the biggest impediment that we need to watch out for, or, you know, maybe dismantle before we go ahead and implement these things. Well, maybe let's start in the same order. So, you know, Mark, why don't you talk? Yeah, what do you see as the biggest impediment, and what do we need to get started with in-home services?
So I'm glad that I'm glad this conversation started to take a turn towards the ineffectiveness of retributional legal action. You know, you know, we're in a moment, aren't we, as a country, and certainly as a state and localities, in a conversation about how our criminal justice system, and particularly as it regards the homeless population, it doesn't work. It's broken. And you know, we've been on a long curve to talk about the integration and the understanding of behavioral health care as part of overall whole person care. And we are a very advanced state versus other states in understanding how mental health is just a part of as a part of the whole person. But we still have a very long way to go to really fully integrate our understanding and appreciation of how mental health is a reality for all of us. You know, I think I would start by saying that I think the first thing that has to change is we have to accept and understand that homeless people are us, except without housing. That until you have, and for many people, until you have a brother or sister or a family member, or until you experience mental health issues yourself, you don't really understand that. You think of them as something other than yourselves, as not part of us. And so I think that we have to start by saying, this is us. These are our fellow Americans, our family members, our brothers and sisters. And so we need to be treating them differently than we do, not simply saying, I don't want to see them and I want them off my sidewalk, or I'm uncomfortable with their behavior. So you and I talked about this the other day in our prep session. I think the biggest problem that we have is the way in which our government funding structures are siloed. And so in particular, the line that exists between the money that is in medical health care, which includes the behavioral health world, and the money which is in human services, don't touch anywhere, even all the way to the top of our federal government. And so that you have people who are in power structures that are supported by funding structures which don't collaborate or align well. And I think it's really the job of you, the politicians, to force that collaboration, whether you do it by integration of systems, whether you do it by sheer dint of force, however that works from a management perspective. I think the fact that all of us who work in sort of human service areas and that touch into behavioral health see every single day the problem of housing dollars versus mental health dollars versus medical dollars. And let's all be honest, most of the power and the money in that structure lies in medical dollars. And I think some of the more advanced programs that we see are when whole person care begins to assume responsibility for human beings and says, housing is a physical right. And when you put people in housing, they get better. They get better physically, they get better mentally, they are more part of communities, their whole person is treated. And so I think that anything which pushes towards the integration of services into a whole person entity and treats people like humans rather than people who must stay within lines and are in buckets is a good policy.
Mm-hmm. Yeah, that's right.
Big answer. Sorry.
That's right. Housing is healthcare.
But it's not healthcare all by itself. And
Right.
No offense, I think Keith knows this coming from the housing world, but now working in Veterans Affairs, that housing itself is sometimes the single answer works for somebody, like for families, it often can work just to have a house, because it's just a financial problem at that point. But so often it's not a simple solution, it's a multiple of solutions. And so it's the coordination of those efforts. It's providing the support in housing, it's providing food in housing, it's providing social work intervention at the street level. It's never a one size fits all and a simple solution for people. But we all know this, so I don't know why people aren't making it work better, because we all,
Yeah. Yeah, well, there's definitely some steps we can take towards that. That I can see here relatively quickly here in the county, right? And one would be to explore, putting some of these relatively quick build pallet homes or tiny homes at our county health campus, right? The Emmeline complex, at least as sort of a midterm housing solution. And that way it's adjacent to some of these other health services. So that's one potential solution that starts moving us towards that direction, I think.
Yeah, I don't want to hug this conversation, but I think that I guess I want to say that the number of people that we're talking about relative to how we perceive the problem is really relatively small. And what this takes is a certain amount of money and will to spend that money and address the issue and bring those people back into a set of programs that really service them. And I think that certainly housing first and tiny villages and places where you have county land, it's one of the biggest problems when we look at LA and San Francisco, is that we don't really have space to build the type of housing structure that he said this, that we need on many levels. I mean, everybody needs housing. It's not just the mentally ill who are currently homeless. I mean, we have working families who need housing. We have, there's a housing shortage across the whole place. So using county resources to, I loved the Bishop Street project. I think that was a wonderful solution where we repurpose an old building, like you're talking about doing with Emmeline, and create housing, because without housing, you can't really connect to people, and you can't solve the most basic of needs, housing and food.
Yeah, that's great. Yeah, thank you for bringing that back to the Bishop Center or facility there in SLO. I noticed that too. Keith, what is the, again, most enabling thing that we could do to support programs like yours, and biggest impediment to?
Yeah, well, first of all, Mark hit it on the head. He said many of the things I was thinking initially, right off the bat. I think it starts with the government, with policy, how the funds are spent. That's why we need people like you in office who will accept and utilize some of these ideas, us coming together from different fields to come up with solutions together, because I think what Mark said, it's a whole person that you have to solve. I know, Amanda, you probably are so sick of me talking to you about my pet project.
Oh, not at all.
Right? Which I believe, I think the whole concept of it works is just, taking that interim housing model that we have and that we've utilized, where we treat the whole person, getting them ready for permanent housing, and taking that and making like tiny homes on steroids, making permanent housing using that same model. I think having permanent housing where you have case managers, access to medical care right there on site, and security, because these people are going to need it, just like all of us go through situations. I think that's big, to get that together, getting all of us service providers, a big think tank together. And I would even say putting people who are homeless or formerly homeless on those think tanks as well. They live that life, currently do, and getting their input to find out what works and what does not as well. And then, as we have done before, look at from all over the country, find out what works. Like you talked about the Cahoots program, see what we can tweak it to make it fit our particular area. But some of these ideas are great. Find out which ones don't, and don't even waste our time with it as well, and don't waste the money on it. And I think if we get together like that, and then know our audience as well. If you put us together, I come from the homeless background. I'm going to be concerned about that. Put me in the room with the developer, and there's a way we can work it out. I can show you how, if we build these homes, that it can be recession proof. You're going to always get your income if the government's funding it through a voucher or what have you. You may not get the high profit angles that you want, but look at something like that to keep you afloat, and you're helping out. And then really touch on the moral issue that these are our brothers and sisters. It's me and you. A bad turn. I'm lucky that I'm work on the front lines, but I easily could have lost my job, and next thing you know, I'm in the same situation. And there's a lot of families who are going to be faced with this real soon. And what are we going to do about it? And even with the temporary interim housing, people have put people in the hotels. Well, what's going to happen when the hotels go, okay, we're back to normal, get all these people out, where are they going to go? So I think we need to start planning this now, because it's going to cost the society a lot more in the future.
But I just want to follow up on that a little bit there, Keith, because you mentioned the hotels and that are, currently with Project Room Key, they're housing people. And you also mentioned your pet project, which is, as you said, sort of a tiny house village, or veterans village. So, what would be the most enabling thing for programs like yours? Would it be, a piece of land that you could actually implement a program like this, or, would it be?
Yeah, funny you say that, huh?
What's that?
I've been asking you about that.
Here's the ask. Quick. Here's the ask.
Yeah, I mean, like seriously, I've been working with some developers that have developed it's almost like a fancy RV type of model that you can build from start to finish with a year. They just ship them, build them. They're just like apartments. They're like the tiny homes, but they're 2-bedroom units. You can make them 1-bedroom units. The biggest problem is the land. You can only need an acre of land, a little bit more for parking. And that can be a quick fix to get some of the people off the street, and even those that graduate from the bridge housing or tiny homes. And that concept has the community room, has a place for medical, place for caseworkers, and security right there. And especially with the veterans, they want that sense of community with them, so people share some of the same issues that they have, and you have someone who can address those, experience with that, and people who are like them as well. So I think that's a quick fix. So land is the problem, and getting the land zoning issues, but I'd be talking all day if I got into the politics of that. That's your issue when you get elected to deal with.
All right,
we'll come with ideas and have the project and be ready to go.
That's right. All right, I think we can find some space for you.
Okay.
Jill, I know, again, you've got all kinds of great programs. How did you get them off the ground as far as identifying the funding in the county budget and getting them funded and growing?
Well, as I was listening to Mark and Keith and to you talk, I think that part of it, I mean, you mentioned I've been here for a long time. I'm trying to use low light so the 30 years doesn't show on my face. But I think, you know, sometimes it's tenacity, it's taking the long view. And so like a project like Bishop Street, it was a building on county property, so it took creativity on the county's part. It took tenacity on my part. It took about 8 years actually from idea to grand opening, and that was super complicated because it was an old building, unreinforced masonry, other than a Native American burial site. It had every kind of complication on it. But but I think that being really creative, and also for it, you know, for you in a position as a supervisor to demand flexibility and creativity from your department heads and from the county. You're absolutely right. Homelessness, behavioral health, substance use, public health, those are all within the county's purview. And so I think it's a time of being really flexible, being willing to put investment forward. I think that's really critical. So the programs that I think Keith, Mark, and I have talked about, if you just looked at them on a spreadsheet and you'd think, holy cow, you know, that's hundreds of thousands of dollars. Yet when you look at some of the numbers, like what Mark's describing in terms of reduction of jail days and all those sorts of things. So not only does it reduce the trauma of being incarcerated or, you know, being, well, even being homeless. I mean, all those sorts of things are really traumatic, and they're just completely, only have negative consequences. So if we really look at these investments, then I think it changes the complexion. But the way every single one of our projects has worked is a police chief who said, I want to pay for a social worker on my team, or a housing authority director that said, I'm going to put 70 Section 8 vouchers out there because I want to make a dent in homelessness. For me to say, I'm going to just say we have to build some more housing specifically for this homeless, mentally ill population, and then sticking to it and figuring out how to do it. So it's complicated. And it can be costly, but I think if you just continue to show good outcomes with the projects you do, you engender a level of trust with elected officials and with the folks who are in charge of the funding and financing. And honestly, I think creativity, people who are flexible, who aren't territorial, who think, you know what, I'm in this for the greater good. Those are the kinds of people you have to have working with you, you know, in the county departments. That's the only way these kinds of things work. And then, of course, partners like us, you know, the nonprofit community who's willing to step in and help figure it out. And we are a scrappy, resourceful lot.
Mm-hmm. Mm-hmm. Right. So I'm hearing you say an entrepreneurial spirit is the key ingredient there, and just start. Right. It sounds like, you know, if we start doing this work, then we'll be able to see some results, and it'll gain a certain momentum itself. That's great.
Like I said, will is everything, right? Mm-hmm. It takes not just population will, not citizen will, but it takes political will. Political will, in fact, drives everything. Citizens can, you know, we advocate really hard constantly with politicians at all levels, but you have to have politicians who see and agree with the benefits. That's when change happens.
Well, I agree with you very much, Mark, and I think that's you know, that's definitely what I see a lot of happening with my own campaign and in our county right now is that momentum towards something new and to doing things differently and breaking through some of that inertia. So it's 6:44. We've just got about 15 minutes left, and I want to make sure that audience members get a chance to ask questions. So I've got a few here. In the Q&A, you can ask questions. If you use the Q&A function at the bottom of your screen there, and I will start looking at that now and answering. We'll pose some of these. Let's see. Here's a question. Do we have a law in Santa Cruz County that protects minors from being transported out of state to rehabilitation centers? you know, I know a little bit about, I know that I've talked to constituents who had minor transported to Napa County, I believe, because there were some specific mental health services there that we couldn't offer here in the county. That's the extent that I know about this as far as transporting people to, you know, the most appropriate place for care. Can any of you panelists comment on that as far as like when we might, you know, use resources from other counties or operate on a larger level?
I have limited knowledge. We have an adolescent treatment program, and I believe a parent or guardian, or in the case of a foster child, that there does have to be permission for moving, for transporting a minor to another county for treatment. So it does need to be done sort of in concert with existing family members. If that answers the question, yeah, they can't just be moved by the county without alerting family members, from what I understand.
Okay, thank you. Our next question is from Lisa Sheridan. She says, Santa Cruz County seems to want to build new housing, new buildings, rather than taking older buildings or commercial buildings and redesigning them for housing. Can anyone speak to why that model, which seems more expensive, can't be done here, that model of reuse? I've heard that funding is the reason. Keith, you're the one I think closest to actual construction of new housing. Can you speak to that? You know,
well, I can compare it to. I can't say all the projects that go on in Santa Cruz County, but some of the same things here. People have looked at like old hotels, trying to redo them and make them housing. Many times with some of the structural changes that need to take place. Sometimes with asbestos, anything like that, land use issues, it costs more money to rehab those houses, a big project like that, than to go from the ground up when you're already building to specification.
Yeah, earthquake retrofitting can be a really big, expensive topic with old masonry buildings, which is what you see with a lot of old government buildings and schools and things like that. So that cost of retrofitting can be, and let's also just let's come back to politicians. California is code crazy. It is a really, you know, we need to build more faster, and everything just slows our process down horribly, which is why we spend more money building transitional housing while we're waiting for the permits to build permanent housing.
Correct.
And it's just, you know, we could really use some expedited coding for, you know, certain classes of projects, possibly. Not talking about building cheap, just there's a lot of permitting and a lot of bureaucracy, government bureaucracy, that's in the way of expediting construction, be it rehabbing or new construction. And it adds to the cost tremendously. I mean, San Francisco, it's terrible.
Keith is right, though. It is cheaper to build new than to renovate old. I'm a sucker for an old building, and so we've done a lot of renovation of older buildings. But it does, and Mark is exactly right. If it's seismic issues, it's whatever other kinds of retrofitting, you have to bring it completely up to code. There are a lot more rules when you're building affordable housing, the kind of housing that Keith builds, and that we've built on a very small scale. So it's kind of heartbreaking because there's some pretty wonderful old buildings. And that the orphanage is an example. It was empty for 40 years because it was an unreinforced masonry building. And many people said, why don't you just knock it down? So it takes a real silly person to go through the whole process.
Yeah.
Well, also, particularly with public projects, you also have to make sure that everything is ADA accessible, and old buildings are just so poorly designed from an ADA perspective. It's much easier to start from scratch to have the right size doorways and stairs and elevators and bathrooms and things. So easier to tear. Yeah.
And also some of the older buildings have historical protection that you can't change a lot of the structures and things of that nature to do them.
Yeah, you know, a significant incidence of disability in the homeless population, and obviously people who live on the streets, as we know, age more rapidly and have more disabilities from their time that they're on the streets. And so having accessible units is a really critical part of this work anyway.
That's true.
That's interesting, right? Okay. Beckpour asks, Santa Cruz already has a mental health worker assigned with LE in each area of Santa Cruz. How is HOT in slow different? I don't know what LE stands for, but
Law,
maybe Jim.
law enforcement.
Oh, sorry. Okay,
Yeah.
there you go.
Yeah.
Uh,
So to answer that question, our HOT team is independent of law enforcement. So they go out just as social workers and nurses and case managers. So they would go out, like let's say they're in your homeless encampment that you showed the slide of, Manu, they might go there and just kind of talk to people, see if mental illness is the primary reason that they're homeless. But it's the HOT team is really focused on mental illness, whereas the social worker connected with law enforcement is working with anyone that the law enforcement folks feel like would benefit from a social worker as the first point of contact.
Okay, got it. Connor Licoli asks, are the psychiatrists in Santa Cruz County trained to get people off of medications just as much as they are to get them started on medications? I'm not a psychiatrist practicing in Santa Cruz County. I don't think any of you are, so I don't know if you can answer that directly, but you know, Mark, I guess maybe since you deal most with healthcare, you know, is there, can you play any role in trying to maybe optimize people's medications? You know, certainly there are, you know, there are cases where we can oversubscribe, and it helps to have people really make sure that they're only taking what they need to. Does your team do any of that? Or do you just fulfill the, I mean,
No, our team doesn't do it. I mean, I think, again, we're talking about a structural problem.
yeah.
You know, while I certainly wouldn't suggest that you know, I think any of us who have had surgery recently in California know how hard it actually is to get an OxyContin prescription and to get it renewed. I mean, I think the system has been well developed to sort of try and control on that. But the problem of getting somebody onto medication that they become addicted to and then getting them off medication are two entirely different worlds. And generally, you don't see, once someone, I think, slips into addiction, they often slip out of the medical system that got them there and into a very different system of care that tries to get them out of that. And so I think those are two different conversations in two different worlds.
We have a couple of psychiatrists that we work with, so I can't talk about Santa Cruz-based psychiatry, but it depends on the philosophy of the psychiatrist and what the individual person is interested in. I know lots of psychiatrists complain they're sort of forced into a role of just being a prescriber, and that's got a lot of limitations. But I know in our psychiatrists, they're really conscious of trying to have that conversation, and if somebody wants to minimize their medication, it's really about symptom management though. And so it's a discussion about, gosh, how is your depression? Are you able to function? Are you able to get up out of bed? If you have schizophrenia, are voices or hallucinations, are they inhibiting you from functioning and getting a job and those kinds of things? And so in an ideal world, a psychiatrist would just try to titrate that medication to exactly what a person needs. If they're homeless and coming off the streets, sometimes it's really kind of more of an art than a science to try to figure out what the right medication is, especially if somebody hasn't been treated for years and years. And I think, Mark, you talked about all the physical issues that homeless folks have. They actually die 20 to 25 years earlier than the average American. So people die in their 50s and 60s. That actually, in the first year of 70 now, the saddest part was that we had 6 people pass away in the first year because they had so many untreated physical health conditions. So anyway, so I guess psychiatry is, you know, it's part of the whole process, and a good psychiatrist is a good listener.
Yeah. I just want to add to this that I think that people, you know, there are people who move into homelessness because of addiction or because of psychiatric issues fall off the radar of regular medical and behavioral health care. And so one of the great things about trying to reconnect people with services and get them into housing is that you can get them back into regular observation and get them. So, you know, people who are living homeless on the street don't have easy access to medication. They don't they can't get their medications mailed to them by Kaiser. They can't, you know, they have problems with, you know, getting into pharmacies and getting prescriptions refilled. And so often they're using medications that they find on the street, which compounds the problem. So I think, again, stabilizing people in housing and get them back into regular treatment where they can have regular access to medication and then regular access to care, which can help them control the amount of medication they're utilizing.
That's exactly.
I think also that what helps with that is having good case management and having a good advocate for those people as well that can describe some of those symptoms and issues that people are having, that they may not be able to do that to a health provider. So I think that's another part of it as well. So I always believe in having supportive services with the individual as well.
We see a very, very big difference between the folks that we care for in permanent supportive housing who are already in the safety net again, who are already being cared for, versus the folks that we're caring for in the Project Turnkey hotels who are just coming in off the streets or out of shelter systems and are just attempting to reconnect with stability and access. And so they're two very different populations, which is why it's really important that people come through a continuum as they move back into long-term stability. They need different types of services when they're in encampments, when they're coming into shelters, when they're coming into their first level of transitionary housing, which we all know this, versus once they get into some permanent housing and they sort of can move along that continuum to a better level of support.
Mm-hmm. Yeah, that's a great point, right? The easiest way to optimize someone's care is to have them in a stable living situation where their lives are not changing every day.
Yeah, that's the home first model.
There you go.
and getting them there, there's it's just a very risky situation when first, it's also true, I would just say, of transitioning folks from nursing homes back into the community. There's just, when people have these big life transitions, it's hard to stabilize them. It's a risky moment for anybody when they become homeless, when they move back into housing, when they move from institutional care systems back into the community. These are all very hard moments, very traumatic moments for humans. And I think that having the right level of support and care in that moment is what's really important to their success at being able to be stable long-term.
Right, that's interesting. I'm gonna just try to get a couple more questions in here. Stephen Plum asks, I find the social worker first model very appealing to de-escalate conflict. Are there any studies that document the benefits of this policy?
That's a great question. I know that our model, the police chief in San Luis Obispo knew of this model from other communities that she'd researched. She actually came to California from Arizona. I know Los Angeles County has used it. So I don't know of studies off the top of my head, but I do know that it is emerging as a more and more frequently used technique. So that's a great question. And I'm sure a good Google search would probably show a few good studies.
Okay, thanks. This is a question from Darius Mosenine. I hope I'm saying that right. He's a landlord and he's rented to 5 formerly homeless people, only to have to evict 4 of them. Many homeless don't have the skills to live in an apartment, follow community rules, pay PG&E, etc. How do you accommodate this class of homeless folks? And I think, Mark, it's fair to say that's kind of exactly what you try to do, right? Is with in-home supportive services.
Sure. I mean, I think on a basic level, you just taking someone off the street and putting them into any type of housing and not giving them any type of support or connection to that adjustment is bound to lead to failure. People need full wraparound services, and at some point, workforce development services. At some point, they simply need case management and living skills. Independent living centers, which I'm sure you have one in Santa Cruz County, are really good at sort of rehabilitating people, and that's an important word, right? Teaching them to live again, teaching them how to the sort of social norms and structures of being in buildings. People coming out of nursing homes have lost their ability to manage money, so while they might get funds, getting funds and then having no capacity to understand what to pay first and how to manage a budget. I mean, we have grown adults who have houses and jobs who can't manage budgets very well. So the expectation that someone who has their first general assistance checks or something are good at managing funds, you can't just put people in housing and expect them to succeed. It doesn't work that way.
Yeah, and to piggyback on that, all of our programs, say we put them in shelters first, our interim programs are designed to provide all the wraparound services, provide life skills, teach them how to budget. And those programs can run from anywhere from 60 days up to 2 years to prepare them for, like you said, you can't just go from streets to put them in those positions. And that's why I think all the models that we're talking about have those supportive services. And the case management, again, and assessments are critical on the front end, that you're getting consistent and accurate assessments so you can make good action plans. develop and find out what their needs are, and how to help them and move forward. And then they have goals they need to hit before we would even put them in permanent housing. And based on that, our success rate of not getting people to relapse and come right back into needing our services improved dramatically over the last year since we've been implementing those type of programs.
I would recommend that a great willing landlord like Darius would connect with a nonprofit that's offering this, because exactly as Keith and Mark just described, those services are critical. They haven't lived on the streets for years and can immediately translate into living independently. So I love that he wanted to house those 5 folks, and I would absolutely encourage him to enlist the help of a nonprofit that does this exact work. I think there's something on the chat from a case manager who's working with young adults, and that would, and in Santa Cruz, that would be a great person for him to connect with.
Yeah, and I would like to shout out my wife, Tamiko, is a case manager in Santa Cruz. And I know even when they graduate those individuals to go to permanent housing, there's still a time period where they can still offer case management services with them while they're still in permanent housing to help that transition period. So I would urge him to utilize those type of services, find out where they came from, and see if that is a possibility to make that a successful transition.
I really think that we need to urge our homeless services brethren to think of transitions from the street into housing the same as people who are transitioning through drug recovery programs. You know, in early stage drug recovery, in the first couple of weeks, people are fully occupied. They're in groups, they're in meetings, they're monitored and assisted and helped. They have group support around them. And I think it's really no different from people who are experiencing mental health issues who come into housing as well. We need to use that same sort of model, which we're very good at, and transition it over to supporting homeless folks. Not all the population, but some portion of the population need that type of regular transitional support.
That's a great point, Mark. Yeah, I mean, I've heard, both the idea that addiction should be considered a really kind of a mental health issue and vice versa. And so, really taking the same approach for mental health in general as we do for addiction is necessary. Well, we're out of time. I think we could probably keep talking all night, but I want to be respectful of your time, panelists and participants. Unfortunately, I'm going to have to bring us to a close here. I just want to thank you all again for joining us. I think you all have that entrepreneurial spirit that Jill said is necessary. And so it's really inspirational to see these solutions happening in other communities. And I know I'm certainly inspired to bring them here to Santa Cruz. And we'll certainly be reaching out to all of you to continue the conversation about how we can do that. For everyone who joined us here tonight, we have copied your comments and questions, and we'll make an effort to get back to you offline. But thank you again for being part of this conversation. And we have a lot more work to do clearly in our community, but I think we're at a major turning point where we have an opportunity to address these in a significant way. So, yes.
Thanks for having us.
Thank you.
Thank you.
Yep, thank you.
All right. Good evening, everybody.
Bye.
Bye.